is a CT analysis of the glenoid OCD in adolescent baseball players. We don't have any relevant. The OCD mainly occurs with the convex articular surface, such as the capitulum or the taladome, but the glenoid OCD is the concave side OCD, as known as extremely rare disease. The purpose of this study is to identify the characteristics of the glenoid OCD and evaluate the recovery of the lesion after operative rehabilitation. For 11 years, 60 cases was retrospectively reviewed. The mean age was 50.2 years. The dominant shoulder pain and the posterior shoulder tightness were presented in all patients, and the anterior shoulder pain was more than half. We measured the region and evaluated the fragmentation or the posterior glenoid sloping. To classify the lesion, we divided the glenoid into anterior and posterior half, and the posterior glenoid was subdivided into three segments: superior, mid, and inferior. After diagnosis, all patients stopped throwing and kinematic chain rehabilitation was performed. For an average of 16 months, his functional recovery and return to sports timing was checked, and the recovery of the lesion was evaluated. And we compared the demo data with the 60 age-matched players without shoulder pains. The posterior glenoid sloping is a typical relative change in adolescent baseball players, but it was not definite or the minimal changes in patients with the glenoid OCD. There was 15 laterocent lesion and only one fragmentation lesion. We measured the size and area, and the proportion of the lesion to total glenoid was about 18%. The 89% of the lesions were located in posterior half, and the mid-posterior account for 75%. Interestingly, it is the most convex portion of the posterior glenoid. Compared with the control group, the statistically significant factor is the higher BMI and the posterior shoulder tightness. To patients who are lost to follow and to patients who stopped playing baseball, finally 85% of the players returned to throwing at an average of 6.9 months. In 10 patients who had the seriously follow-up, the region recovered 50% at 6 months, and the 6 patients had nearly complete recovery at 13 months. There are several case reports, especially from Japan, where only one English study was reported, but not about the baseball players. Our study is the first case series of the glenoid OCD in adolescent baseball players. The significant loading exerted on the posterior glenoid after late cooking and repeated osseous impingement makes the posterior glenoid sloping. The glenoid is thought to be a variant type of internal impingement in skeletal immature athletes. Considering that all patients have posterior shoulder tightness and higher BMI, without posterior glenoid sloping, the pathomechanism of the glenoid OCD is thought to be slightly different from the typical posterior glenoid sloping. Although the posterior superior shifting occurs in late cooking, the most prone area is the mid-posterior region. As the scapula tipped forward 15 degrees, it is thought to contact more often in mid-posterior rather than posterior superior glenoid. There is no consistent strategy for treatment, but young, small, and shallow regions are more effective in conservative treatment. In this study, 85% of the players successfully returned to sports after a conservative treatment. There was only one fragmentation case, and maybe the region stability was well maintained because the glenoid is a concave side OCD, so even in a fragmented lesion, it can be treated with the conservative treatment. We found that lesion recovered 50% at 6 months, and the healing proceeds from the peripheral to central direction is similar to the capitular OCD. Our study is a retrospective study with a small case, and we had no concurrent MRI study. Conclusion: the glenoid OCD is a rare type of internal impingement and rarely fragmented, frequently occurred in mid-posterior glenoid, and can be successfully treated with rehabilitation in adolescent baseball players. Thank you.
I may have missed it in the presentation, but what was the treatment? Was there surgical intervention, and do you have outcomes on those?
The half means the total area of the lesion. And 85% of the players return to sports.
Okay.
And the half of totally recovered of the lesion, and our half said 50% of the lesion was recovered. But the symptom is recovered in 0.5% of the recovery patients group.
Okay. Do you have experience in those that don't respond to conservative management and perhaps have detachment of their lesion? What intervention do you make in that circumstance?
We have no surgery case in adolescent baseball players. In adult case, one fragmented loose body was removed, but the surgery is not about the region, such as the microfracture, or it was just remove the loose body.
Okay. So just removal of the loose body and nothing for the lesion itself?
Yeah.
Okay.
Hi there.